So good morning. It is such an honor to share some thoughts with you on NHI today. But firstly, I want to inform you that I will be donating prizes for this event. These spot prizes will go to 25 brokers who attend the launch today, and post the launch we will inform you of the final winners. Please note that my presentation will also be qualifying you for CPD points, and the CPD certificate will be provided you after you've done an assessment and passed the assessment. Details to follow post the launch. So our agenda consists of 6 parts, but that will be dealt with briefly. So let's go on to the first topic, which is the healthcare systems that operate globally. This section deals with 4 main healthcare systems that exist globally. The Beveridge model fund healthcare provision directly from income tax deductions, and most hospitals are owned or operated by government. Most healthcare staff include doctors and nurses that are employed by the state. So the UK National Health Service operates this model. One of the main advantages of the Beveridge model is that healthcare services are free at point of service to every citizen. The government is responsible for funding all health services upfront with the money raised from tax deductions, and the healthcare systems that operate the Beveridge model are frequently beset by long waiting lists for treatment. The Bismarck model operates differently. It is known as a social health insurance system, where the healthcare system, which people pay to fund, that in turn pays for the healthcare activities that can be provided by the state-owned institutions, other government-owned institutions, or private institutions. Countries such as Germany, France, and Switzerland have adopted the Bismarck healthcare system. The Bismarck healthcare system usually has significantly higher accessibility to lower waiting times, thanks to the competition between the consumer-oriented healthcare system. National health insurance, on the other side, uses elements of the Beveridge model and the Bismarck model. And countries like Canada, South Korea have operated the NHI model. In this system, government is a single payer for all healthcare services like the Beveridge model, but under the NHI model, funds are raised through state-operated insurance schemes that every citizen pays into. And most healthcare service providers are privately owned companies, as in the case of the Bismarck model. This system can also lead to long waiting queues. According to Canada's Fraser Institute think tank, the median wait time for medically necessary treatment in Canada was 20.9 weeks in 2019, and in some regions it can actually increase to almost a year. The last model that I want to touch on is the out-of-pocket model. This model is a method of accessing healthcare that is most common in developing countries where no formal statewide system exists. People in rural areas of India and China, as well as parts of Africa and South America, use healthcare in this specific way. Health services are not always available, and even when they are beyond the financial means of the people. So we need something different. Universal health coverage means that all people have access to a full range of quality healthcare services when they need it and where they need them without financial hardship. It covers the full continuum of essential health services, from health promotion to health prevention, treatment, rehabilitation, and palliative care. And that is what we strive for in South Africa. So when we look at the healthcare system of Canada, it is a publicly funded NHI system known as Medicare. The system provides universal coverage for medical necessary hospital and physician services. Each province or territory administers its own health insurance plan, and the funding comes from taxes and government transfers. On the other side, Germany has a dual system consisting of both statutory health insurance and private health insurance. Statutory health insurance covers most of the population and is compulsory for employees below a certain income threshold. Contributions to the system are shared by employers and employees based on income. Private health insurance is available for higher income individuals and offers additional flexible benefits and flexibility. Australia's NHI system is called Medicare. It provides universal coverage for essential medical services and is funded through a combination of taxes and a levy on high-income earners. Medicare can be supplemented by private health insurance for additional coverage, such as private hospital care or extras like dental or optical services. Japan has a mandatory social health insurance system. It covers all residents and is funded through premiums based on income. The system is decentralized with multiple competing insurance funds. The government sets fee schedules for medical services, ensuring affordability and access to care. This section focuses on the reason government provides why NHI is appropriate for South Africa. So government wants us to believe that NHI is about Ubuntu. We take care of each other as a nation in times of need. NHI is the South African way of providing access to high quality healthcare for everyone. And government says that national health insurance is a way of providing good healthcare for all by sharing the money available for healthcare among all the people. The health benefits that you receive will depend on how sick you are and not on how wealthy you are. If we can feel and act in unity about football and rugby, surely we can do the same when it comes to matters of life and death, health and illness. None of us would like a fellow human being to die, become disabled or live in pain just because he or she could not get decent health care. That is what government wants us to believe. So how will NHI actually work? So under the NHI, you will still have access to your preferred clinic or hospital. If you seek treatment in that facility that is not registered with the NHI, or if you wish not to follow the referral pathway, your expenditure may not be reimbursed. This will necessitate you to pay then cash out of your pocket for the services rendered by that particular facility. When you see a nurse or a GP, they will attend to you and decide if you need a specialist. You will then be able to get a level of care that you will need according to the criteria that they have set for you. So the question in the mind of every intermediary and member of a medical scheme is, how will medical schemes work and what will their role be? And medical schemes will still exist, but will not be able to fund cover that is the same as what the NHI will provide. And we will ask the question, what will it cost? Now, what the government says is that NHI will combine the many public and private healthcare funds into one fund that will pay for everyone when they need access to healthcare, using the advantage of size of the fund to reduce the healthcare costs. Initially, there will be no tax for the NHI. Government will pool the funds that already exist in the public sector to start the NHI. When the NHI is up and running, the Treasury may introduce a small tax to augment the money or allocate it through the public budget, according to what government says in the brochures about NHI. So now, that's what government said, but if we now go and look at what the bill actually says, there was 132 amendments made by the Portfolio Committee on Health to the original NHI bill. After 380,000 written submissions were received, 9 hearings in 33 provinces, 11,500 members attended, and 961 oral submissions made. 114 stakeholders made oral presentations to the Portfolio Committee on Health. The Portfolio Committee on Health received legal opinions from the state law advisors, as well as the parliamentary law advisors and the Freedom Front Plus. So the Act defines a health product. But what I want to convey to you in this slide is a non-legal definition of what a health product is. And you can see that a health product includes a comprehensive set of benefits. such as essential services to maintain your health, to prevent serious health problems, primary healthcare, emergency healthcare, diagnosis, treatment, rehabilitation, and a range of other services, including palliative services. Now, when we take that definition and we read that definition with Section 2A of the National Health Insurance Bill, it states that the purpose of the Act is to establish and maintain a National Health Insurance Fund in the Republic funded through mandatory prepayment that aims to achieve sustainable and affordable universal access to quality healthcare services by serving as a single purchaser and single payer of healthcare services in order to ensure the equitable and fair distribution and the use of healthcare services. This means that you cannot purchase healthcare services. Remember the comprehensive definition of the health product from any other entity than the state. So who will be covered by the NHI Bill? It is citizens, permanent residents, refugees, inmates, and then children that will receive certain basic healthcare services. Asylum seekers, illegal foreigners, and certain categories of foreigners will receive limited cover under the NHI. This is quite an interesting slide where we talk about you need to register your beneficiary on the NHI system. So parents can have the duty to register their children, but children can also, between the ages of 12 and 18, register themselves. But you have to provide certain biometric information. Fingerprints, photos, proof of residence, your identity document, original birth certificate, which may prove to be an administrative challenge, as I don't know where my original birth certificate is. And I have to also provide my refugee ID card, which I am not a refugee in South Africa, but the bill is written that I must provide that document. It's not an or choice that is given, it is a compulsory document that I have to submit. So what are my rights under the NHI? And you will have the following rights: to receive quality healthcare at point of service, to receive information regarding your benefits, to access the records regarding your own health, and not to be unreasonably denied healthcare services, not to be unfairly discriminated against, and not to be subjected to unreasonable delay. And remember what I said about single-payer systems in Canada, where the delays are sometimes longer than a year. Our law says you will not have that in South Africa. And to receive a professional standard of care, and to make reasonable decisions regarding your health care. And then under the NHI, you also will have the right to lodge complaints and appeals. You can also request written decisions or reasons for the decisions that was taken. But you don't have the right to receive an answer on that request. You can request it, but you don't have a right to receive an answer. It would have been helpful if we had a clause to say you will receive an answer within 30 days or 20 days. But if you need emergency care and you request a reason why you can't get it, a delay in an answer or not giving an answer at all will not help you with your rights. So when people ask what will be covered under NHI, this specific section deals with it, and it says that the Benefits Advisory Committee will determine healthcare services that beneficiaries will be entitled to. And then they go on and they say when certain services are not available, what you will have. If this specific section 7 is unclear to you, you are correct. It is as clear as mud. So what will not be covered under NHI? And again, what is not covered is again still unclear. But they say that if no medical necessity exists, if no cost-effective intervention exists, or if the product and treatment is not included in the formulary. Look at the words. The treatment is not included in the formulary. A formulary is not treatment itself. We call that a protocol. So where will government get the money to fund NHI? And I initially said that there will be no tax for NHI. but the bill seems to have a different implication. The NHI will be funded from general taxes, reallocation of tax credits, and the payroll tax on employee and employer. So what government says in the marketing material about NHI is factually not what stands in the NHI bill. The Minister of Health also have the power to regulate certain aspects. And the first one is the legal relationship between the fund and various healthcare establishments and service providers and suppliers. The legal relationship is established by certain law, such as the Companies Act, the law of contract, the law of obligations. Therefore, it is totally improper to bestow this power onto the Minister of Health, and is a total overreach of his powers. There's various other aspects that the Minister can regulate, like the budgeting process, the clinical or diagnostic codes. Again, there's a confusion in the wording with protocols and formularies, and in participation in the NHI healthcare information system. The Minister also has certain powers to issue regulation about the registration of users, the accreditation process and procedures, and functions and powers of district health management officers. The Minister again have power to develop and maintain the formulary. Again, no reference to the protocol. Suppliers of the NHI fund, the reporting processes and types of reporting of healthcare establishments and providers to the fund. And again, the relationship. Here they take out the legal relationship, but just a relationship between the public and private health establishments. The Minister of Health also has the powers to regulate the following: maintain the performance of the fund, fees payable to the fund, but this conflicts with Section 49, as Parliament actually allocates funds to the NHI fund. How money must be invested. So when regulations are made, usually the public can participate. Now the Minister must provide 3 months notice if the Minister intends to make changes to regulations, unless the Minister thinks that it is in public interest not to follow the public participation process. This can have serious consequences to undermining the principle of participative democracy and consumer rights. We saw that in the COVID situation where we couldn't wear short pants, and that was a regulation made. Minister can do that in terms of the NHI bill. The NHI bill is poorly drafted and contain many uncertainties, conflicting clauses and irrational clauses, and clauses that impact the constitutional right of citizens. There is a high likelihood that a bill, if enacted, will be challenged in the Constitutional Court. This section deals with some of the possible constitutional challenges that we can expect. The NHI bill is a money bill and is known as a framework legislation. Framework legislation has certain challenges. It creates a certainty vacuum until subordinate legislation is enacted. By its nature, it defers the legislative process and can potentially allow too much subordinate legislation with limited parliamentary oversight. This may lead to inappropriate discretionary power in the hands of the Minister. Our Constitution is framed on the principle of participatory democracy, but subordinate legislation may reduce this. This may lead to constitutional challenges. There are some general principles of legality that legislation must adhere to. The law must be clear, certain, rational, and accessible. The exercise of public power must be within the bounds of the law and consistent with the Constitution. When this matter is referred to the Constitutional Court, the Constitutional Court will most likely consider the following to decide if the National Health Insurance Bill meets its constitutional muster. First of all, they will do a textual interpretation, so they will look at the words that is used. Are the words consistent with the Constitution and specifically the Bill of Rights? Their consistency between sections, or does the one section contradict the other section? Does the proposed bill contradict any other established law, like the law of contract? Are the discretionary powers of the ministers appropriate? Are there any limitations of rights contained in the Bill of Rights justifiable? And then the court will look at the purpose of interpretation. So what is the purpose behind the bill, and is that achieved? The last aspect the court would look at is the reasonableness. And is the bill itself reasonable? It would be reasonable if the bill doesn't diminish or detract from existing rights. Does the bill create new rights? And is that rights that is created justifiable? Does the bill promote progressive access to equality healthcare and prevent unfair discrimination? Does the bill promote right to fair and administrative action? When the court looks at rationality, accountability, responsiveness, openness, limitation of rights, the considerations can be whether the bill as a framework creates too much uncertainty, such as uncertain about the benefits. Can the bill be rational if the framework is not clear on the level of benefits? Can the bill be rational if the role of stakeholders are not clear, such as private healthcare sector and medical schemes? And can the bill be rational if it is unclear how the money bill will be funded or how much funding is required for the bill? The bill also confuses healthcare delivery and healthcare funding. And is this rational? I would submit not. Framework legislation can only be rational if the minister's powers is defined and boundaries are set for subordinate legislation. Sadly, this didn't happen. This section deals with what happens if the bill is not passed or if the bill is struck as being unconstitutional. And when this happens, it will mean that we will have the status quo, that the public healthcare service will further deteriorate, that the private sector will become more expensive, our GAP products will become more expensive, and all citizens in the country will suffer, with the emphasis on all citizens in the country will suffer. So is there an alternative? This last section focuses on a constructive proposal that FIA made in terms of the NHI Bill. And this is what we represented to the Portfolio Committee on Health, and that we will also present to National Select Committee on Health in the National Council of Provinces. This proposed transformed healthcare system comprises of the following. Firstly, it focuses on prevention as key focus. All citizens should have access to ward-based primary care and the integrated school health program and emergency care, whether it is rendered in the public sector or in the private sector. And these services may not be provided by medical schemes and are funded from general tax. A set of minimum benefits should exist in the public sector and in the private sector. This will include referral pathways, starting with nurses, then GPs, and then specialists. The integrated clinic will provide specific primary care diagnosis, care and treatment of chronic conditions, and hospitals will be included. These services will be funded from general taxes. As I said, the same benefits will also exist in the private sector. The same formularies, the same referral pathways, the same protocols. And these benefits in the private sector will then come from the medical scheme contributions, and a risk equalization fund should also then be established. Contributions in the private sector must still be based on community rating and open enrollment. The private sector can then also provide supplementary benefits that can additionally be covered by health insurance products or additional higher benefits that you purchase on your medical scheme. Again, that must be community rated and subject to open enrollment. In the public sector, the members will then be able to have access to an ex gratia funding. Mandatory membership must be implemented for people over a certain income threshold that will have to make a compulsory contribution to medical cover. However, these people can opt out of the public service into the private sector. And a portion of their contribution will then be rebated to them, but a portion will be kept in the public service as a social solidarity contribution. Taxpayers should be incentivized for healthy lifestyles and penalized for poor health lifestyles. The formula and criteria should be simple, but should drive the correct behavior. The same should be applied to companies, where they should be allowed a tax reduction for improving the health of the employees and the community around the employer. Which brings me to the clinics. Employer-based clinics must be allowed to form part of the healthcare system where services can be rendered to the community surrounding the employer. And employers rendering these services must be able to claim for the services rendered to the community and or receive a tax rebate or incentive for rendering the services. Public and private partnerships must be established in terms of academic hospitals, nursing and training facilities to ensure that we have the correct production of health personnel. A controversial suggestion is maybe the delayed prepayment. Healthcare is not free. Someone must pay. While social solidarity will reduce or require the unemployed not to pay for healthcare services, an appreciation of the cost of healthcare needs to be instilled. When the unemployed are employed, they need to repay a portion of the free services that they received. The concept is modeled on the free assist model of the Australian education system. We believe that this supports also the International Labour Organization's observation that healthcare is not a free service. And when people understand the cost of healthcare, the quality improves. Thank you for this opportunity that I have today to talk to the people about NHI and to understand what the impact is. In the meantime, what do we do as brokers in the meantime? In the meantime, we need to keep on guiding, educating and protecting our clients to ensure that their healthcare needs are taken care of. Thank you.